I'm going to deal with the laboratory aspects of thyroid with a stress on the regular thyroid function tests. This has been already covered, that it is predominantly the T4 which is secreted, or thyroxine which is secreted by the thyroid, whereas 80% of the T3 is produced peripherally by conversion or deiodination of T4 into T3. So in a way we can consider T4 as an pro-hormone which gives rise to the more potent, 10 times more potent active hormone, which is the T3. 99.97% of T4 and 99.7% of T3 hormone are bound to plasma protein, predominantly thyroid binding globulin, as mentioned by Dr. Phadke. So, this table briefs the same thing about T3 and T4, that T4 is predominantly the hormone secreted by the thyroid, whereas the peripheral conversion is involved in making T3 available, which is more active or more potent than T4, which is again mentioned here. Free T3 and free T4 are the active hormones. These free hormones enter, These free hormones enter the cell through the THR receptors and act on the nuclear receptors for free T3. These nuclear receptors are of 4 types: alpha 1, alpha 2, beta 1, beta 2. Alpha 1 and beta 1 are present in most of the peripheral tissues, whereas beta 2 is unique to pituitary and is involved in the peripheral negative feedback mechanism. I'm just mentioning about these types because we would then later on discuss about thyroid hormone resistance, where these receptors have alterations or mutations. The thyroid hormone then acts on the nuclear receptor with production of mRNAs and increased protein synthesis, leading to differentiation and cellular growth. It helps in maintaining thermogenesis and the metabolic homeostasis of our body. HPT axis has already been dealt with. Again, the important part is this negative feedback loop which exists between the T3, T4, which is there peripherally acting on the hypothalamus and pituitary through the TR beta receptors. Thyroid disorders are broadly classified into 3 types: the euthyroid states, hyper and hypothyroid states. Laboratory evaluation of thyroid disorders encompasses these tests. Predominantly are the thyroid function tests, that is the total thyroxine and total triiodothyronine, the free T4 and free T3, and the thyroid stimulating hormone are the thyrotropin. The other tests which are available in the laboratories are these anti-thyroid antibodies, certain specialized tests like the TRH stimulation test, we have thyroglobulin level estimations, and of course histopathology and FNOC of thyroid gland. As we all know, these thyroid function tests are the most exploited tests in this clinical laboratory scenario and are more and more commonly involved in screening of normal patients, all adults, even pregnant women, as mentioned by Dr. Phadke. TSH is considered as the single best outpatient screening test amidst these thyroid function tests, except for certain conditions like in hospitalized patients where central hypo or hyperthyroidism is suspected, in cases where there is thyroid hormone resistance, or in cases where there are certain kinds of medications which the patient is taking which may affect the HPT axis. While dealing with the thyroid function test, we should be familiar with the platforms, the generation of these platforms, their detection limits, linearity, sensitivity and specificity. For determining the accuracy of the results, the performance of these platforms or these tests is important, for which we have these CLI acceptable performance criteria to help, and obviously every laboratory practically now participates in the quality control measures and external quality assurance programs. These thyroid hormone levels or these thyroid function tests, as already mentioned, are affected by various physiological variables like age. As we know, TSH is on a higher side almost up to an age of 15 years. then it reaches the adult levels. After the age of 30, it is said that every 10 years increase in the age would increase the TSH values by 0.3 units. Pregnancy has already been stressed by Dr. Fadke. The cutoff for TSH in pregnancy gets down to 2.5 in first trimester, 3 for the second, and 3.5 for the third trimester. As also because of increase in the TBG, the T4 is on a higher times, 1.5 times or 1.5 folds higher than the non-pregnant state. Several pathological variables are involved: thyroid gland dysfunction itself, other organ dysfunctions like hepatic and renal, certain medications, systemic illnesses or non-thyroidal illnesses, and again specimen related or pre-analytical variables. They may interfere with the testing. Presence of human anti-mouse antibodies in a sample may affect the estimation of these assays. The absolute indications for performing these thyroid function tests would be newborns. It has been already stressed that it should be done after 72 hours, and then we of course have certain other conditions like goiter or history of chronic thyroiditis in a patient, history of taking radioiodine therapy, head neck radiation or surgical ablation, suspected Graves' ophthalmopathy, cases of atrial fibrillation and flutter, and for monitoring the replacement or suppressive therapies. Different organizations have different recommendations for getting these screening tests performed. At one end, we have this American Thyroid Association where it says that all men and women over 35 years should be screened for thyroid dysfunctioning. Whereas we also have Royal College of Physicians of London, which says screening of healthy adult population is unjustified. Just to give you a history of how these assays developed, I'm taking TSH as an example, but similar generations have developed for other tests as well. We started around 1965 measuring the thyroid hormones by radioimmunoassay techniques. These were the first generation techniques developed by Odell and colleagues. Then came the second generation immunometric TSH assays around 1980. Initially they used polyclonal antibodies, then they started using monoclonal antibodies. And now currently what we use are the CMIA or CLIA techniques, and these are called the third generation assays with much improved sensitivity and specificity. The sensitivity is 100 times increased over the second generation assays and 1000 times over the first generation assays. Functional sensitivity of TSH is supposed to be superior over analytical sensitivity. The functional sensitivity should be less than 0.0038 milli-international units per liter. There is improved specificity with less than 10% cross reactivity with structurally similar hormones from the pituitary like FSH, LH or beta-HCG. But we should remember that even though this is the single most best test to be performed for screening, there are certain pitfalls in TSH interpretation standalone. In secondary or tertiary hyper and hypothyroidism, in newborns they tend to have higher values. In elderly patients, in patients with non-thyroidal illnesses, in presence of antibodies in the specimen, these are specimen related issues like human anti-mouse antibodies which I already mentioned, as well as IgM RA factor antibodies, and on patients which are already taking medications for thyroid. T4 assays have an analytical sensitivity of less than 1 microgram per deciliter with less than 3.2% cross reactivity with T3. The triiodothyronine or the T3 assays have an analytical sensitivity of less than 0.2 nanograms per ml and less than 0.1% cross reactivity with the T4 assays. When we come to measurement of the free hormones, these free hormones, as already mentioned, are the active forms or the biologically active hormones. Then we also should remember while interpreting these hormones that they may be affected by the abnormalities of the thyroid binding globulins, either the amounts, increased or decreased TBG, or even the binding or the affinity between these proteins and the hormones. Free T4 is very useful in resolving borderline or unclear thyroid function tests.